Good morning and welcome to HIM 205 live event number 2. So this is our AM edition, and we're going to be going through a little bit different than what we went to in live event number 1. So just to kind of run through some of the basics that I always like to include at the beginning of the live events, and that is just a reminder, here's some of the best ways to get a hold of me. Text me at 602-529-6002, or you can always send me a Canvas inbox message or reach out via email. Okay, so I think everybody has the same email. So let me just jump through this. Some of the very important things as we run through finishing up this course include the fact that this course ends on Saturday, September 21st. So what that means is that we are really in the final stages of this 205 course. So again, here's the dramatic red box ending on the 21st. So with today being September 2nd, that leaves us about 19 days to really make an impact in this course. So in addition to kind of looking at a little bit of the content that we have going forward, touching on operative reports and physician queries, also going to be focusing on what can you do if there's any catch-up or anything that you need to do to get yourself in the best position possible as we head towards the end of this course. So just jumping through right here, we have our objectives. So I have listed our objectives for weeks 7 through 9, but really we need to think about we are at the start of week 8, and we have just 8, 9, 10 left. So first things first, and looking at the different types that we're doing, we continue to refine our skills, working through different body systems really with our CPT. So this week specifically going into integumentary and musculoskeletal system coding, and next week, respiratory system procedures. Beyond that, we have week 10, which is really going to be focused on a discussion question and our final assessment. Okay, so I'll have more information on the final exam, that final assessment, in our PM edition later this evening. Okay, so also just a reminder on our timelines, as you can see on here, Monday, September 2nd. So of course, we're in the AM edition right now. PM edition is at 8:30 p.m. That's Eastern time, also 5:30 p.m. Pacific. Okay, so as we start off looking at operative reports, this is something that we get a lot of exposure to. Doing procedural coding, we're going to see a lot of operative reports. Is not always, definitely not cut and dried when you're talking about just a diagnostic statement or a physician's charge sheet or something like that, which helps us to work through CPT coding, even maybe more along the lines of E&M coding. But as we work through CPT, a lot of what we're going to be doing as coders is looking at operative reports, procedure notes, whatever they might call it. Okay, so you're going to have, there's actually several different names for operative reports. You could have, depending on the specific procedure being performed, you could have endoscopy reports, you could have cardiac catheterization reports. You can have a lot of different types of things, but it really all boils down to there's just more specific names for operative and procedure reports. So as we look through this, going through an operative report, you're going to kind of make your way through the document, and that's how you're going to be able to figure out what codes you need to do. So you can see here listed in the bullet points, review the header of the report. So what you're looking at that point is who is your patient, what is the indication for surgery, what is the preoperative diagnosis. They're actually going to give you your postoperative diagnosis. If there is any pathology sent out, that type of information. Next, you're going to review the CPT code book. So you're going to start in the index, right? So as you make your way through there and you're looking at this report, you are reviewing the report, looking at the documentation, trying to decide where you're going to start for that preliminary code selection. Once you do start down a pathway with a certain code, of course, you're going to review the guidelines for those codes, looking for any exclusions, looking for any further instructional notes. Then you're going to review policies and eliminate the extras. So some of that as well has to do with, we have coding guidelines, we have different things that we're instructed via the coding tools that we have, but also within our organizations, or maybe even for the surgeon that you may be coding, there may be specific rules, maybe even contacts that we make with the physician to get additional information. And we'll talk about those in just a moment, because those are actually called physician queries, and it's a formal process. Okay, and then of course, once we make our way through, again, reviewing policies, eliminating the extras, we've identified those codes through the help of our coding guidelines and whatnot. Now we add any needed modifiers. And sometimes that can be a little bit of the tricky section. But again, you're making your way through. So let's talk just a little bit more about these operative reports. So who's completing them? Well, these operative reports are actually documented usually by the primary surgeon, can also be documented by a resident that may be assisting, can be documented by an assisting surgeon, and then sometimes there are surgeries where there may be multiple surgeons that do different pieces. So if you have maybe a multi-system procedure, you have a specialist that comes in the middle, you could have one surgeon that opens up the patient, initiates the surgery. You have another specialist that comes in and now they perform the next section. They will then depart and the original may return, or even another specialist may come in. So you could, in theory, have 1, 2, 3 surgeons that are completing operative reports. They don't all complete the same operative report. They will complete their portion. So a lot of times as a coder, you're going to be going through and you're going to be reading the operative report, and you may see that it says, then hand it off to, doctor whoever to do this portion of the surgery. Then you need to look for that additional operative report. And if you don't have it, then that's something that you have to ask for. You cannot proceed with coding of the case until you have all components. So what is the operative report? Well, really it's something that looks at a lot of different things, identifying the course of what occurred during that operative suite encounter. So you're going to have, again, the diagnostic information. You're going to have the demographic information. You're going to have things like estimated blood loss. You're going to have things like the anesthesia level, all those types of things that really give you an acuity level for the patient as well. Where do you find this operative report? Well, a lot of times you're going to find it depending on if you're in a paper-based record or an electronic health record. You're going to find it among the physician documentation. So quite often you would find the operative report really preceding the pathology, maybe even preceding the anesthesia. There's going to be a lot of times, whether it's, again, electronic or paper, it's going to be what we consider an an operative packet, right? All the things that would go along with it, which would be pre-op and post-op and pre-anesthesia and post-anesthesia, the operative report, the pathology, all those types of things are actually going to come together and make the operative packet. Okay, but that is all stuff that you're going to need to look at as a coder, because again, it could spawn additional questions for you. If you see something noted by the anesthesiologist and it's not noted by the surgeon, that could be an opportunity for a query. So why do they document this operative report? Well, for several different reasons. It is partially a requirement. That is a really good reason to do it. It's required by CMS. It's also required by Joint Commission, as well as professional associations. So if you have any sort of accreditation, all you're required to do are operative reports. But probably the most foundational reason for doing an operative report is for continuity of patient care, right? So while it's created for patient care, we utilize it for a lot of different things. We can utilize it for billing, we can utilize it for credentialing, we can utilize it for research, all those types of things. But the core purpose for the operative report is for continuity of care, to support that patient care encounter. Okay, and then when is this completed? Well, again, there are requirements that tell you when it needs to be completed. Joint Commission, CMS, in alignment on this one, they require that this is done within 24 hours of the actual surgical encounter. Your organization may have tighter timelines. They cannot have looser, but they could have tighter. So your organization could say, you know what, 24 hours is too long. We want it on the chart sooner than that. They say that it needs to be done immediately post-op, which they could even quantify as, say, 4 hours post-op. This needs to be created. So again, it starts off with the requirements, but they can be tighter within an actual organization. Okay, so again, I've alluded to this several times. Physician queries, what are those? Have you guys encountered physician queries before? Well, I have a few things to present in regards to this. So physician queries are something that they are completed by either the CDI team or the coding team. So what is the CDI team? That's the Clinical Documentation Improvement Team. A lot of times comprised of either nurses or coders or even HIM professionals. Those individuals look at the record during the active visit. They may look at it after the active visit, but usually during for the CDI. And what they're looking at is there any sort of lack in specificity? Do we see anything where information contradicts? We may have one thing in the consultation report, but we could have something else in the discharge summary. Are we looking for those things to be in alignment with each other? And they should be. So CDI or coding will come along and they'll ask questions and they'll get clarification. And that's really what a physician query is. So you can see here on the snippet that I've included from the Journal of the HEMA article, it says a query can be a powerful communication tool used to clarify documentation in the health record and achieve accurate code assignments. And then they provide some examples, and we'll look at those in just a few minutes. But what we want to look at is really what are some of those pitfalls with a query. One of the things to be very careful about, especially when you're in the coding environment, you always need to be on the lookout for. You do not want to find yourself in a position contributing to or creating an environment of fraud, waste, and abuse. So what does that mean? Well, queries can fall into this, not so much fraud, right? Because fraud is really the intention to deceive or intentionally submitting false claims, intentionally driving something. But with a query, it could be more of a case of waste or abuse, which means that you just don't have good practice. If a coder is writing a query and it is not following certain rules or is trying to drive a physician to what could be perceived a higher paying code, that could be fraud, waste, and abuse. Okay, so again, some of the obstacles or pitfalls for a well-written query. So what can kind of trip people up, or what can even get you into an audit situation where they're going to look at your queries? And again, to be audited by CMS over your queries, that nobody really wants to be audited by CMS. Okay, so some of the obstacles are vague or leading questions. So what does that mean? Well, that means that you're putting your query together and either you're not giving the physician enough information to know what you're talking about, or you're maybe giving them too much information and asking it in such a way that you're leading them down a certain path. Like you have in mind the code that you want them to select, so you're kind of driving them there and saying, I would suggest this, this, this. What do you think? Well, you can't quite go that far, okay? So you need to be very careful that you're not leading them in a certain direction. You're not making suggestions. It's just the facts. Another obstacle, poor content. So what does that mean? Well, that means that perhaps you are not providing the physician with the information that you are actually pulling from. What is it that you've looked at that now has you questioning or needing additional clarification? You need to spell it out for the physician. If you are not telling them, well, I see here in this place, and you do a copy paste of that, so they know exactly what you are referencing. If it is, again, vague, or you're not giving them enough detail, or even giving them the right information, they're not going to be able to respond to your query. Comprehension. So again, very important that you are relaying it in such a way that the physician actually understands where you're going. What are you trying to ask them? You need to be very clear in what you're asking them. So again, not leading them, but asking them in a certain way. And that's where templated documentation requests are so important. And then finally, are you getting the granularity that you need, right? So if the physician is responding to you, but not responding to you in such a way that you actually have clarification following that response, you need to follow up, because a huge obstacle is to ask the initial question, not get the answer or the level of detail that you need, and then you're not following up. So very important to follow up. If there needs to be a second query, and this does happen on a fairly regular basis, that's fine. But ideally, a well-written query will get the answer that you were looking for, again, that clarification the first time around. So what are some of the attributes of a well-written query? Well, again, templated documentation requests. This is going to assist you in terms of not creating leading questions. It's going to line out how it is that you respond to every physician. And basically, when you go to query a physician, you're going to be able to bring it up and just start plugging in information instead of having to craft from the beginning. So again, you're going to, oops, I have a typo here, you're going to note the condition or diagnosis already in the medical record. So again, you're going to kind of call it out, okay, based on this that I saw in this documentation, right, maybe I need clarity. I don't see that it's mentioned again in the discharge summary. So you're adding a statement or additional data that's pertinent to the question being asked, and then you're asking a question with a focus on obtaining more specificity, right? So in that example, let's say that I saw a condition mentioned in the H&P, and I see medications on the active medication list to where they are giving this patient those medications throughout the course. Yet when it comes to the discharge summary, I don't see it mentioned again. So I would tell the physician, okay, based on this in your initial, your initial assessment, your initial plan of care, you stated this. And it is visible in the medications that the patient is currently on this medication. Can you please clarify, did this continue to be treated during the visit? I do not see it noted in the discharge summary. I mean, there's different ways that you can say it. So you can see that'd be something that you could replicate over and again. Can you please clarify? This is in the H&P. I do not see it listed in the discharge summary. And the physician could come back and say, no, you know what, that was actually resolved. We did not actively treat that, or that was incidental, whatever it might be. Okay, so also important to include in terms of an attribute of a well inquiry is include a statement to alert the physician that they're to use their medical judgment, right? They're not just going to agree with CDI or the coder, that they're to use their medical judgment. And again, that kind of puts you into a position to where you're not going to be questioned for fraud, waste, and abuse. If you ever went under audit, they'd be able to identify that you had all of these things in place to best support, again, physicians using their professional judgment. So I do have some examples right here that we've pulled out. So the Journal of AHEMA, a fantastic resource. And again, this was posted in 2013, but it is still relevant today. They give examples of different types of queries. So here's what you can see where one that may be a leading query and a non-leading query. So you always want to go with a non-leading query because the leading query could be an issue with fraud, waste, and abuse and could get you audited. So here's the scenario. Patient is admitted with pneumonia. The admitting H&P exam reveals white blood cell count of 14,000, a respiratory rate of 24, a temperature of 102 degrees, heart rate of 120, hypotension, and altered mental status. Patient is administered an IV antibiotic and an IV fluid resuscitation. So a leading question would be, the patient has elevated white blood cells, tachycardia, and is given an IV antibiotic for Pseudomonas cultured from the blood. Are you treating for sepsis? So by presenting the physician with a diagnosis, that would be considered leading. So this better one, a non-leading, and you can see it's very organized. They've pulled together all of that relevant information. So based on your clinical judgment, so again, that disclaimer, this is not about what the coder is asking you to do. This is not about what the CDI nurse might be asking you to do. As the physician, based on your clinical judgment, can you provide a diagnosis that represents the below listed clinical indicators? In this patient admitted with pneumonia, the admitting history and physical examination reveals the following, and then they put into bullet points all those things that we read in the scenario. Please document the condition and the causative organism, if known, in the medical record. So right there, you are not leading the physician down a road at all. You're stating the facts. They have not addressed this. You believe it could be something more, but it's not noted in the discharge summary. Now you're laying it all out for the physician and then just asking the question, right? And you're directing them as well. Go ahead and document if it is something, right? And so here we have another one, for example. This is a multiple choice query. So this is saying where they're trying to get more specificity, right? And this one is more in alignment with both of these actually with ICD-10, right? With doing the diagnosis coding, but it works the same when you're talking about within an operative report. Again, you don't want to lead a physician, you want a non-leading something. So if they're not giving you the level of detail, if they're not giving you the size of a suture, right? If they're not giving you maybe enough detail on their entry point, whatever it might be, you're going to need to write a query. So this one here, again, focus on a diagnosis code, but still kind of looking at this. A patient is admitted for a right hip fracture. The H&P notes that the patient has a history of chronic congestive heart failure. A recent echocardiogram showed left ventricular ejection fraction of 25%. The patient's home medications include metopropyl, lispro, and Lasix. So a leading question would be, please document if you agree. So you can see right there, you're creating a suggestion, and this is not a true, false, or a yes, no type of thing, right? You need to present them with the information and then have them fill it out. So this non-leading one, it is noted in the impression of the H&P that the patient has chronic congestive heart failure and a recent echocardiogram. So you're restating what you already see. Noted under the cardiac review systems reveals an ejection fraction of 25%. Can the chronic heart failure be further specified? So what they're really doing is giving them all the different options that they have and asking the physician to specify, is there something more to this? I don't have enough information. So by multiple choice, you're saying those really are things that the physician can come back and say, no, it's undetermined, we don't know why, or, oh, yes, it actually is chronic. They're going to be doing those things, but it's not a one-to-one. Okay, so again, you can have some yes, no's, but again, it could be because they've stated two different things within the record and you're getting that clarification. So again, very important. You can kind of see as you go through these, you're identifying what information you found in the record, where you found it, and then spelling it out for the physician to use their clinical judgment to then give you clarifying information. And that's something that's so important. Again, as a coder, make sure that you are on the right path and that you have the information you need to be able to get that accurate code. Okay, so that is it for this AM session of our 205 live event number 2. But this evening, we'll be having live event number 2 PM edition. And in that one, we're going to be looking at medical terminology as well as our final assessment. All right, so just remember, the effort that you put into things is what you're going to get out of it. So the best project you'll ever work on is you. I'm going to focus on what can you bring. Again, we wrap up week 8, 9, 10. This is the time to bring our best selves. All right, thank you and have a fantastic rest of your day.